Okay, chapter 8 is going to cover film mounting. I know some of you have already had a chance to mount either your guide wings or your additional periapical, and you're kind of learning how that whole process is done. But there is a procedure or how you should mount. Mounting is central. I would say almost just as essential as taking the films itself. You can take a great radiograph, but if it's not mounted correctly, then you could be causing a big problem. If it's mounted incorrectly, especially if someone's having a procedure done, and you have your film backwards, what if they're working on the wrong tube? Because you didn't mount it correctly. Okay, so mounting is very important. Okay, so we're going to talk about film mounting. There are different types of film holders. Okay, we have several different types. The full mount that we have right now, I don't particularly care for it too much. But I'm sure it was on sale, and she ordered a lot of them, so we kind of have to use them until they're all gone. So the purpose is for film mounting is to present the basic concepts of film mounting and viewing, okay, to describe the step-by-step procedure that must be followed to prepare for the interpretation of the dental radiographs, okay. You are allowed, as when you're done as licensed hygienists, to interpret, to mount and interpret the radiographs. Again, you cannot diagnose. Even as silly as it may be sometimes, and you can interpret the radiograph. We're going to talk about the basic concepts, normal anatomy and film mounting, normal film mounting methods, and step-by-step procedures. It helps that if you're learning anatomy now, so you may have to take a little bit of what you learned in anatomy in order to be able to help to mount your film. Okay, because you will use anatomical landmarks. Sometimes you will use fillings or restorations to help you. Okay, so mount. To place in an appropriate setting as for display or study. That would be the definition of mount. Okay, film mounting in dental radiography is placement of radiographs in a supporting structure or holder. Okay, all films that you expose and process should be at some point mounted. Okay, with the patient's information, chart number, the date, and actually everyone's a little bit different with the information they write, but who exposed those radiographs. Sometimes the doctor's name is there, sometimes your name will be there, the assistant's name will be there, but basically the patient's name and chart number and the date are really essential. Now, again, like I said, there's different type of film mounts. There are cardboard film mounts, there's plastic film mounts, there's some that are vinyl, and basically they're used to just arrange and support the radiographs in an anatomical order, okay? A lot of them are opaque or they may be clear. I prefer the kind of clear ones. The opaque mounts, they kind of mask any surrounding light, which is nice when you're trying to interpret them. And they're available in different sizes and configurations. Okay, here are several different types. This one's the cardboard one. Here's a clear one here. This is the one that's kind of masked with the black around it. Because what you do is you put this and you put that on the view box. So the light comes in through here, but any extraneous light is blocked out by the black here. But the cardboard does the same thing. Okay, this would be an example of a mount. And basically, it's pretty much how your mount goes. You have here you would have your maxillary molar, your maxillary premolar, your molar bite wing, premolar bite wing on the right side, mandibular molar periapical, the premolar periapical, and you have your maxillary centrals, your lower centrals, maxillary premolar on the left, maxillary molar on the left, your premolar bite bite wing left, molar bite wing left, premolar periapical on the left, and the molar periapical on the left. Okay, this is not exactly the one we have. These are okay too, actually, but sometimes the film, you put them in these little notches, but they tend to pop out. If they're in the chart and someone pokes it from behind, it's easy to lose a radiograph. Okay, so who can mount the film? Okay, any trained dental professional, the dentist, hygienist, an assistant who has possessed knowledge of normal anatomical landmarks of the maxilla, mandibular, and related structures is qualified to mount film. Okay, usually mounting film is responsibility of the office dental radiographer. Now, you could be in an office and the assistant takes all the radiographs and they mount all the radiographs. That's fine. But you know, every office has its own dynamic. If the assistant calls in sick one day, they may ask you, "Oh, can you take a set of bite wings?" Okay, a good set of bite wings. Okay, so you should always have pride in your radiograph. Okay, if you are in there with a patient and you have any doubt that I'm not sure about that shot, then don't take it. Okay, either get some help or say, you know what, let me reposition that. Okay, and just make sure, just like, I'll take it, I'll see how it comes out. No, okay, because you'll learn later that this is not Dexter. Okay, every shot you take is an cumulative dose for the patient. Okay, which is important. So you have pride in your radiograph. Okay, so when and where should films be mounted? It should be mounted after processing. Okay, it requires you want to have a nice, clean, dry, colored work surface in front of an illuminator, or view box. The room should be kind of dimly lit, pretty much the way it is here now. When you go to the viewing area, that little area that we view films, the upper lights should be off, really. The only lights that should be on is the one coming from the bottom of the view box. That's how you should be viewing radiograph. Why use a film mount? Okay, well, it's kind of self-explanatory, but it's quicker and easier to view and interpret. They can be stored a lot easier and available for interpretation. It decreases the chances of error in determining the patient's right and left sides. Okay. Some have gone so far as to put you can put a little R and an L. You're a little unsure of it. I think somebody has done that to one of the Dexters. Dexter has an R and an L on his head somewhere. I don't remember who. It decreases the handling of individual films and prevents damage of the emulsion. And again, it masks any illumination adjacent to the individual radiograph. So what information should be placed on the mount? The patient's full name, the date of the exposure, the dentist's name, and the radiographer's name. This is according to your book. Here, it's a little different, and when you go to work, it might be a little different. So normal anatomy and film mounting. Again, identification of landmarks will help you to distinguish maxillary periapical films from mandibular periapical. Okay, you guys haven't gotten to anatomical landmarks yet in anatomy, right? No? But you'll learn on the maxilla, you have what is called the maxillary sinuses. Okay, so you will see that on your radiographs, even on Dexter. The bone on the maxillary is not as dense as it is on the mandible. The mandible, the bone is very condensed. It's very tight. Okay, so you should be able to distinguish. Okay, in the maxillary, how many roots does the maxillary molar have? 3. Mandibular molar? 2. So when you have a shot that you're unsure of, this is the max or the mandible, look at the roots. Okay, if you see 2 roots, distinguish 2 roots, this is going to be the mandible. On the maxillary, you're not going to always see 3 roots like this, okay? Because you have one that's a mesial root, distal root, and a palatal root. So it's like this, okay? But you also want to look at the pulp chamber. Look at the pulp chamber of the mandible and compare it to the maxillary. The pulp chamber of the mandible it's a lot bigger. It kind of has like a little H pattern. On the maxilla, the pulp chamber is more just kind of a round circle. Okay, so you'll use little tips like that and little anatomical landmarks to help you differentiate the max from the mandible. Okay, but it does take some practice. But you also have your identification dot, right? And you all know the dot goes where? The dot goes in the slot, okay? So if your dot is always in the slot, it's going to help you when it comes to mounting, because you'll find that all of your maxillary periapicals, the dot will be down towards either the incisal edge or the occlusal surface, okay? On your mandibular shots, periapicals, the dot will be, again, towards the incisal edge or the occlusal surfaces. So in your mandibles, the dot would be facing this way, and the maxillary, the dot would be facing that way. Okay, if you have all your dots in the slot. Okay? So again, the identification dot is located in one corner of each interoral package. All dots must face the same direction when they're mounted. Okay? So your dots, there's two mounting methods. Okay? Labial mounting, lingual mounting. Okay? This is the first one. No one really uses the lingual method anymore. So we here use the labial method. With the labial method, again, the dot is raised when viewing if you're on the outside of the patient facing. So you should feel the pimple, not the dimple. Okay, so when you touch your films, all of your dots or all of the bumps should be up. Okay, so that's the first thing you do is orient all your dots up towards you. Okay, so the labial method is me standing in front of your patient. So my right is opposite of her right. Okay, and my left is opposite of her left. Okay, the lingual method is me standing behind her, where my right is the same as her right, and my left is the same as her left. In this case, then the dimple would be up. Okay, but we don't use this one, but you should know it. Okay, we use the labial mounting method. Okay, all your dots are up. Okay, so this is the little raised dot. And then you have, you guys are learning what the curve of SPI is. Okay, so this is a bite wing. So when you have your bite wing, you should have almost like this smile. If we had all four, it should be kind of like this and curve up this way, because you have the angle of the mandible that goes up towards the coronary notch this way. Okay, so you should kind of look for that slight curve of SPI when you're doing your bite wing. So these are step-by-step procedures. It is not, carved in stone that this is how you have to do it and it must be this way, but this is more of a guideline, okay? So put a clean paper towel over the work surface in front of the view box. You turn on the view box. You always want to label and date the film mount. You can wash and dry your hands, examine each radiograph, identify the dot, and place each dot. Place each film with the dot up. Sort films into bite wings with both maxillary and mandibular teeth, vertical anterior periapicals, and horizontal posterior periapicals. So you take your bite wings, you put those to the side, then you take all of your vertical anteriors, right? Put those to the side, and all the rest are horizontal, right? And then you can arrange the films on the work surface in anatomical order. And you want to place the films in the mount and secure it, and you want to also always check the radiograph. Okay, so a lot of people, what some do is that once they have everything separated, they may start with their anteriors, okay, because all your anteriors are vertical. So you go with your central, and then when you look at your canines, you should see some of the maxillary sinuses, And then on the lowers, you won't see the sinuses, and you see that bone. That bone is very condensed. So you put all those together, and then you can start with your bite wings and kind of work your way out from there. I don't put the films down. I put them in my hand and I feel for the dot and I just place them as I go. But I've been doing this for a long time, so it's a lot. That's my system. So you will come up with a method that works for you, but this is one that's having you just separate them so that way you can arrange them according to anterior, bite wings, and posterior. Okay. It may make it easy. Okay, again, this was the same one, but now this is kind of by, this is 1 to 3, and then 3 to 5. But basically, this is how it would be mounted. Now, here's a mount, but this is a little different. Here at the University of Ohio, they use a central lateral shot. So central lateral, and then canine, canine. And again, we talked about, and even in radiology, as you're getting critiqued, okay, as you're critiquing yourself, do not put horizontal angulation for your canines, okay? If your instructor's taking points off of that, you were told that it's almost impossible not to have overlap on your canines, max or mandible, okay? So then you would critique these, and a part of critiquing these is knowing, anybody lose points on this? Knowing what should be there, okay? So you start here, if you know that you should have the distal to second premolar and everything back, and you see all of the premolar, then you have what? Packet placement, right? Everyone get that? Okay, if you see here, I have the whole second premolar. So this film should be back a little bit more. I should only see half of it. And what else do you see on that picture?
Overlap.
I see the third molar, but I see overlap.
Yeah.
Yeah, I'm looking for errors.
Oh, okay.
Okay? So then you want to do that going through the whole FMS. Okay, so you should be learning how to critique your FMS. So film viewing, obviously it's just an examination of your radiograph. And again, all members of the team that are trained may interpret radiograph, but it's the responsibility of the dentist to establish a final and definitive interpretation and diagnosis. Okay? Again, your light source, it should be large enough to accommodate and with a variety of different type of film mounts. Basically, your view box. The light should be kind of a uniform intensity and evenly diffused. Magnification. It is nice, and that's one thing I wish we had in our viewing area is a magnification. Okay, you have those in the clinics with the little one you slide back and forth. Right now, you've just been cleaning it. You haven't really used it. You just know how to disinfect it. Very well, right? Okay, but this is basically your basic view box. You would just clip your films in here, and you kind of slide that along to look at each individual film better. It's hard to really just with the naked eye. Some stuff you can see, some you won't. Okay. Again, it's best to have a dimly lit room. And again, this is a step-by-step procedure, but not etched in stones. Examine films for unerupted, missing, or impacted teeth first. Then you can look for any suspicious lesions and the size and shape of the pulp cavities. Okay, remember I told you the mandible is a lot bigger than the maxilla. Any bony changes, the level of alveolar bone, and then calculus. Look at the roots and periapical areas for any radiopaque or radiolucent pathology, and any of the other remaining areas. Helpful hints, again, use the view box, avoid holding the films to the light. They call this the airplane method. And we all do it. You get a film, you I can't see. Yeah. So it's not ideal, okay? Again, if you have a magnifying glass, that's best. you want to view the films immediately after they've been mounted, and you want to view them under optimal conditions and use a definite order to view films, and then you want to record those findings in your patient's record. All right, so let's just say that we know that the dot is facing up, okay? Where would that go? What shot is that? Give me a show of hands. One person. Yes. 22. Well, where is it going to be mounted? Lower left. Lower, that's.
Well, you're going to mount it on the lower right, but it's the lower left.
We're going to stick to that. Okay, so it's a lower left canine shot. That's a canine shot, right? So why do you say it's the lower?
Because you don't see any mounted inside.
Right. You see how tight the bone is, very tightly condensed, okay? So she's saying that's the patient's lower left, okay? Which for you, it will be your lower right, okay? But you're mounting as if you're looking at me. So it's this, it's for me on this side, okay? I know. I'm your patient, so you would mount it on this side.
So what's to the left?
Well, if it's a canine shot, it's 22. Because if you, well, let me just click the next. I forgot there was two. Okay, so so we already said it's a mandible. All right, so that I forgot there was two. You didn't say if it's a max or mandible. So we decided it's a mandible. All right, so now you're really, it's the same shot.
Why upside down?
Because I want you to tell me if it's a max or mandible.
That's the mandible.
It's a mandible because I said how tightly dense, and we don't see any maxillary signage. Okay? Trust me, for your exam, there'll be a lot of this going on. That is 22. Because, it's the other way because I'm standing in front of you. Okay, so number 22 on me would be here, right? My left. Right. But it's you're mounting on me. You're mounting as if you're standing in front of your patient. So raise your right hand. Ours are opposite. Okay? All right? Again, you got to work on this. All right? So you may not agree with why that was your lower left. Okay, but well, eventually. So here's our next one. Maxillary or mandible?
Maxillary.
Okay. How many roots do you see?
Well, I see two.
Oh, you see two. So that tells you what?
It's a mandible. And it's a premolar shot.
How many roots do you see? Okay, so that should tell you what? It's one is a mandible. Okay? If you look at the roots, I mean, if you look at the pulp chamber, this one's not that, but you have it here, it's kind of an H pattern. Okay? You distinctly see two roots, but look again how tightly packed the bone is. Okay? So now, is it the patient's, so which shot is that? Is that a molar shot or premolar shot? Premolar shot because we have the distal of the canine and everything back. Okay, so where do I mount this? The patient's right side or left side?
Right, lower right. Right. Lower right. Lower right.
How many say lower right? How many say lower left?
Lower left. Lower left.
How many are going? I have no clue for what's going on right now. Okay, I respect your honesty. Okay. So is the patient's lower right premolar? Hang on. Well, and that's a good way because the roots, they do curve back this way a little bit, correct? Okay. But if you know that, if you've already determined that, okay, it's not a maxillary, and that the dot is up and this is the way it goes, you can't mount this on this side because that's not the way your teeth go. Your teeth don't go molar, 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 premolar, premolar, central, right? They have to go from here, big teeth, to small teeth, right? So you can't take this and put this here because then your centrals are going that way. Okay, does that make sense? I see some of the wheels are starting to turn a little bit. Okay, let's try another one. Max or mandible? Somebody else. Let's see. I'm gonna start calling on people. Maxillary? I see some frowns. They're saying that. Why is that? Okay, so here's the maxillary sinuses. Okay, this is called the inverted Y. We're jumping ahead a little bit. This is the inverted Y. Okay, you can see it here also. So we know that this one is the correct orientation, right? So we have here a molar, a premolar, another premolar, canine, lateral, central. This is the canine shot. Okay? Pardon me? They all look the same? This is the sinuses here. This is actually the floor of the sinuses. This is the sinus here. Okay? So, with that being said, where does this get mounted? Up there. Patients, right?
Right.
Maxillary right. Crystal, you agree? You agree? It's maxillary. Okay, she said it's maxillary left. Can I take this and put this over there? Because remember, we got big teeth, premolar, canine, central. So it has to go over here. Because we're going big to small. That is a bridge. Okay, patient's maxillary right canine. Okay, because again, your teeth go like this. Big to small. Okay, your molars, premolars, and then anteriors. So you can't take this and put this over here because then my big teeth would be coming this way and my small teeth would be going that way. Max or mandible? Mandible, she said. Anyone say maxillary? Anyone afraid to say anything? So here's a good example. Look how big that pulp chamber is. Okay? How many roots do you see? 2. Look at the bone, how condensed it looks. Okay? Do you see any maxillary sinuses? No. Okay, so we know that this is the correct orientation, right? Do you see the curve? Do you see the curve of speed going up this way? All right, so this is the patient's. This what shot is this? Molar shot. Patient's what side? Mandibular left. Okay. Some of you are getting hot now. You're getting it. Okay. It's not a good shot. Yes. All right. Max or mandible? I heard max. Okay. Maxillary. Do you see any maxillary sinuses? Look at the bone. Does the bone look very tight? Okay, mandibular. Okay. It's tight compared to. Hang on. See how this is not. It's not. You don't see that same compress. No. It's not tight compared to this.
Is it the actual bone?
Yes, I'm looking at all this trabeculae bone. It's very tightly packed. Okay? See how tightly packed it is? But this also has another anatomical landmark that I don't know if you're familiar with.
That's it, because they are smaller.
Right here, what is that? Well, that's the genial tubercles and the lingual foramen. I don't know if you know that yet. The radiolucency is the foramen. The outside part, the radiopacity, is the genial tubercles. You're not there yet. Okay, it's all right. But you would see that, but look, the bone is very tightly condensed. Okay, look how small the teeth is. Those are upper central. No, they have to be lower. right?
Oh, well, yeah.
So is that the patient's right or left side? I was just checking to see who's still awake. Anterior, right in the middle. Okay. Some of you were thinking, let me know. All right, max or mandible? What do you see?
The sinus.
See the maxillary sinuses? See the difference in the bone structure? We don't see that trabeculae, those squiggly lines going through it. Look at the pulp chamber. You can barely see it. It's a slight little circle. Ideally, you don't see the 3 roots, but you don't see distinctly 2 roots. Okay? So is it a premolar shot or molar shot? Premolar. So which one is the correct orientation? This one or this one? This one. Okay, so that makes this the patient's what? I heard it right. It's the patient's left, because if we put this on this side, then we have the molars first, and this canine is going this way. So that's the correct orientation. Max or mandible? Max, what do you see? Maxillary sinuses. Look at the pulp chamber, kind of circular. Okay, so this is the correct orientation, right? It's a molar shot. So this goes where?
Maxillary left.
Upper left.
You agree, Zay? So say, you agree? We're going with the majority decision? Everybody? Yeah, so it's the maxillary left, right? So this is slide this over here. All right, everyone has seen these nursery rhymes before, right? For the most part, no? Jack and Jill went up, did they? Okay. Anyone who haven't seen it? So what did you see?
Jack and Jill. The bucket.
You didn't see any teeth? No, there was no teeth. No, but it had, Mary had a little line. And Jack and Jill went up the hill.
Can't even see them.
Oh, we can't see.
It's a little dark here. Well, like you would have saw it anyway. So sometimes it's about interpretation. Okay, so you have to interpret. Some people might see things on certain radiographs that you don't. Okay, but uniformly, you should be able to interpret your own radiographs based on what you've learned. You know that for premolar shot, whether it be bite wing, max, or mandible, that you should see the distal of the canine back. For premolar shot, whether it be bite wing, max, or mandible, second premolar back. If you know that, and then you know that you shouldn't see any overlap on certain films, your vertical angulation should be pretty much like this. You should see the incisal or occlusal of the teeth. If you don't, if you cut it off, then that's vertical angulation. Okay, so interpreting is key. What do you see there?
A frog laying down.
A frog. I see.
You see a frog? Anybody see a frog? Hey, who sees a frog?
I see a bunny.
See a bunny. Very late.
Oh, no, I see the horse. I see the horse.
Oh, I see the horse now.
I see a horse.
Oh, yeah. Oh, now it's
So it depends on if you have your radiograph the wrong way.
There is no bunny.
Yeah, the bunny. You saw a bunny? Yes, you saw a bunny. Maybe that's the person you want to interpret. She's getting there. Yeah.
I seen the horse like 30 minutes ago.
see the front?
See the front.
Yes.
Okay, okay. Make sure they're-
I also saw the sneakers as teal. Some people saw them as pink. All right. So questions. So how are films mounting and what type of mounts are available? How do you mount? Where should you mount films? Dimly lit area. Clean area. What type of film mounts are there? Vinyl. Okay. So what information is placed? What information should be placed on that mount? There's a variation, the dentist name and the radiographer name according to your book. If I ask you that question, I may say according to NBC, okay, or I say according to the author.
What's MPC?
Miami-Dade College?
No, what's the point?
The patient's name, their chart number, the date, and then your name. In the best conditions, we said dimly lit room and everything else. There's a mounting exercise there that, and also in this chapter 28, in the student resources, there's a mounting exercise that you can do too. I highly recommend it for those of you who couldn't quite grasp the right side, left side. Again, it's a click and drag. All of the radiographs are already oriented upward. Okay, so don't think that you have to turn it over. The dot is always up. Now, for my quiz, the radiographs may not be oriented correctly. You might have to do this. Okay? Or I see a lot of people doing this with their hand. But you might have to do that. If you look and you see two roots, then you know that it's the lower, right? And you just kind of visually turn it over and put it in its place. All right?
But
Yes.
sometimes for the maxillary molar, you see only two roots. Sometimes, right?
Yes, so then it's rare that you're going to see the three roots on a maxillary molar. So, but now what I'm looking at is I'm looking for other anatomical landmarks like the sinuses, and I'm also going to look at the size of that pulse chamber. On the maxillary, it's going to be very circular compared to the mandible. The mandible, it's usually a lot larger. Okay? I don't think I changed anything. The key points for chapter 15 is a lot of the vocabulary. Okay? Because everyone, as far as what they do, as far as decontamination, hand washing, they have different protocols. We have, I think, a very pretty stringent protocol. We have you wash your hands quite a bit. I won't go through all that detail, but here from this chapter, the vocabulary is something you're going to want to make sure that you have down. Some of the questions: what's the rationale for infection control? What infection control procedures are necessary before, during, and after exposing your radiographs? And what infection control protocol is necessary for processing? Infection control and the dental radiographer, these are some of the guidelines, and again, they may be a little different from what we have here at NBC. So infectious disease presents a significant hazard in the dental environment. I think we all know that. And infection control protocols are used in dentistry to minimize the potential for disease and transmission. Okay, a big thing here is it's called cross-contamination. Okay, touching something that's contaminated, and then with those contaminated gloves or your hands touching something else. Okay, and that's why you're not allowed. If your pen falls on the floor, okay, you're not allowed to just go pick it up, right? Or if you're, I can't say the other one. It's on the quiz, so
Yes.
I won't give that away. All right, so infection control basics. So we're talking about the rationale for infection control and infection control terminology. So to prevent the transmission of infectious diseases, it may be transferred from patient to dental professional. This is why you wear PPE to protect you from the patient and protect the patient yourself. Dental professional to patient and from patient to patient. That would be cross-contamination. Pathogen. A pathogen is a microorganism that's capable of causing disease. Okay. You'll have the same definition for pathology. Okay. A pathogen is a pathogen. So here's some of the terminology that you're going to make sure that you familiarize yourself with. Antiseptic. Antiseptic is a substance that inhibits the growth of bacteria. Okay. Now your book may have a little bit more detail in there. I was just taking some of the meat off the bone. Asepsis. Asepsis is the absence of pathogens, and that's the type of environment we want. A bloodborne pathogen is a pathogen present in the blood, okay, and usually it could be capable of causing disease. Disinfect is the use of chemicals or physical procedures to inhibit or destroy pathogens. Okay, we use barriers. Okay, we use Pyrex. Okay, you have phenols in that group. You have any type of usually some compound with some type of chlorine. Okay. And disinfection is the act of disinfecting. And you have exposure incident. It's used, an incident involves contact with blood. Okay, so if your glove tears or rips, you immediately want to take those gloves off, wash your hand, and don a new pair of gloves. Okay, because we have, our skin is a natural barrier, okay? But as you know, we can get cuts in our skin, which is considered an open portal infection, and you don't want that. Okay, this is why we cover up our eyes, because you don't want to have something going to your eyes, your mouth, when we wear our PPE. Infectious waste, waste that contains blood. Everything that you have garbage cans in the clinic, not everything goes in the garbage can. Later on, you see that you have another garbage can that has a red liner. Okay, anything that's soaked with blood goes in there. Occupational exposure is contact with blood that involves the skin, eyes, and mucous membrane. Parenteral exposure is basically a needle stick. Okay, in the summer you will be learning how to give local anesthesia. Okay, like it or not. Okay, hopefully we will have local anesthesia mannequins by that time. Which means that you won't have to, well, at one point, you won't have to do it on each other as much, okay? But you will do it on each other. But you want to be very careful that you don't get an incidental needle stick, okay? You look shocked. Sharp is basically any object that can penetrate the skin. Okay? Needles are sharp. Your instruments are sharp. Okay? Sterilize is use of chemical procedures to destroy all pathogens, including microspores. And sterilization is basically the act of sterilization or sterilizing. Okay, and this is why when you say that your little spiel about the black strip is that it's gone through the sterilization process. You can't say that this strip means that these instruments have been sterilized. Okay, you can't guarantee that until we have another in the dispensary. Anna has another thing that's a spore test. That has to be sent off to a lab. That gets checked to make sure that the machines are running properly. And then that way, you know that those instruments that came out of that cycle, and it comes out with a little report card, that cycle at that day, the machine's working properly. So then and only then can you say that those instruments are sterilized. You can only say that they've been through the sterilization process, which is correct. They should be sterilized. Okay, so some guidelines for infection control practices. Obviously, your protective attire and barrier techniques. You're to put barrier. You know where you have to put barriers for the radiology room. You know where you need to put barriers for your clinic, correct? Okay, so those are things we use to protect ourselves from the patient for us, and patient from patient cross-contamination. Hand hygiene. Everyone knows how to wash their hands now, right? When you come in, you do 2 consecutive 15-second hand washings, and then periodically throughout the day. Okay, when you take your gloves off, you wash your hands. Before you put a new pair on, you wash your hands. Before you touch the lead apron, you wash your hands. When in doubt, you wash your hands. Okay. Sterilization and disinfection of instruments. You put your instruments to be sterilized, so now you know how to wrap them. You know how to disinfect your unit and all the rooms. So, which is cleaning and disinfecting of dinner unit and environmental services. We leave it kind of glistening, right? You don't wipe it until it's dry. PPE, you all have it. I don't think I need to really go into that too much, okay? But just so you know, PPE is when you're working on a patient or a Dexter, okay? You can't just have on your gloves, okay? It's everything. Again, hand hygiene, you know, the nails, the nail polish and the glitter, and, you know, all that stuff is gone for 18 months, okay? Save some money, they'll be there when you get back. Okay, then different sterilization of disinfectant instruments. So we have critical instruments, semi-critical instruments, and non-critical instruments. Critical instruments are any instruments, say like your scalers that you don't know, haven't seen in a while. Anything that's going to penetrate the skin. Okay? A scalpel would be something, example of a critical instrument. Semi-critical instrument does not penetrate skin or bone, so that a semi-critical instrument could be your XCP rig. It goes into the mouth, okay, but it doesn't cut into tissue. It shouldn't cut into tissue or anything like that.
The
Okay?
hand mirror,
What's that?
the hand mirror.
Hand mirror. The hand mirror would be non-critical. Okay, your mouth mirror would be semi-critical. Okay, so non-critical would be the mouth mirror, the lead apron. Okay, non-critical. Film would be semi because it goes into the mouth. Okay. Then you have your different type of disinfectants. You have your intermediate and your low level. Intermediate is used for all surfaces that may be contaminated. And intermediate is used for like general housekeeping. Okay, fabuloso. If you can take the smell, get a good one. Okay, so here's some infection control dental radiography. Infection control procedure used before exposure, infection control procedure used during exposure, infection control after, and infection control during process. So you all know that before you expose the patient, you know, all your barriers are up, you have on your full PPE, think about Dexter. You know, we have a process. During, again, you're wearing your PPE, you put the lead apron on, right? During that, you are still wearing your PPE throughout. Afterwards, you know that you are to basically get all the equipment you're going to need for processing, which is 3 cups, a headrest cover, a new pair of gloves. Now, when you develop automatically, you are not wearing your PPE. You do not wear your gown, you do not wear your mask or your eyewear. You just bring a new pair of gloves. Okay, manual processing, you have to wear a gown and your mask is optional. Okay, but I don't want to catch anybody at the automatic processor with their gown on, with their hands in. Okay, Just clean gloves. That is cross-contamination. With manual processing, which you won't do again, you wear the gown so you don't splash it on yourself. And the mask is optional because some people are very sensitive to the smells of the chemical. Okay? And then infection control procedures during the use. So you know that with those clean gloves, you're going to open up all those films, and once they're open, you separate them. Once they are separated, then you take your gloves off with your hands still inside the automatic processor. You take those gloves off, and you pick the films up, and you run them through bare hands. Afterwards, you take your hands out, you go back to your radiology room, you get your utility gloves, and you get your stuff out of a lot of you haven't done it yet. You do it today, you get it out of the area, get rid of the foil, get rid of the trash, and then you take your little gold envelope and leave it on top of the processor so everyone knows that when those films come out, who they belong to. Okay? If you haven't, you will learn it this week. Okay? We had one group, couple groups through it yesterday. It's not easy on the back if you're kind of tall, so she can testify to that. The x-ray machine, the chair, the work area, the lead apron, you know that afterwards all these things get decontaminated. And with the machine itself, you have to put the machine back, collapse the arms back together. The tube head should be pointed downward, okay? Your chair, it doesn't matter if it's up or down, the light should be off, the unit should be off when you leave that room, okay? That extension arm on the outside, if it works, it should be back down. Okay, your name should not be on the door anymore. Okay, at the end of every lab day, you all know that I come around and I check. I've been lenient so far that I will give you heads up if there's something wrong. Okay, after this week, I will not. Okay, so you leave your name up, you leave the extension arm out, okay, you lose points. You leave barriers up, that's 10 points. Okay, because that's infection control. And preparation of supplies and equipment, the films, sensors is for digital. Again, the beam alignment devices, you put that back, and any other miscellaneous items I already talked about. Preparation for the patient, again, the height of the chair you want, if you're tall, obviously bring the patient up to appropriate height. If you're a little short, don't have the patient way up here so it's difficult for you to see. Headrest adjustment if needed. This is the big one, lead apron. That must get used to always putting that on the dexter, okay? I've already walked past a couple of students that didn't have it, and they didn't always remember what my clue was. If I ask you again, how many films have you taken? I'm asking for a reason. I'm not asking because I want to know how many films you've taken. I'm asking because there's no lead apron. I can look in your cup and see how many films you've taken. Okay, so if I come in your room and you have a patient and I say, how many films have you taken? And that's your clue to go, oh yeah, now for this shot, you're going to need this. Okay? That's what you say to the patient so they don't panic. Okay? Again, hand washing, gloves, mask, eyewear, beam and light, you all have that. Okay? Again, this is kind of the digital. So interruptions during exposure, that if your classmate comes over to you and asks, oh, you know, is this anterior or posterior? That's fine, but you have to keep track of, you know, where you start and when you stop when you take an FMS. Okay, in your radiology manual, there is a FMS for an adult and an FMS for a pedo. You can take that out if you want. You can have it laminated. It has to be laminated. And as you're taking radiographs, you can take your wet, dry marker, and as soon as you take it, you exit off so you don't get lost. Okay, don't exit until you press the button. Okay, then you know you took it. So if you get interrupted, you know exactly where you were. Does that make sense? Okay. You all know how to, again, dispose of contaminated items. The lead foil goes into the red container. Everything else goes in the trash. You have to wash your hands before you handle the lead apron and afterwards. And then you all know how to decontaminate that room. Again, transporting your films, they should be in those cups, new gloves, trash bag. We're not going to be using the dark room too much more, and that is it. So the key to chapter 15 are pretty much the terminology. Okay. So terminology from 15, knowing how to mount for 28. How many film mounting methods do we have, Griselle? How many film mounting methods do we have? Ever. 2. Okay, they are